ECDC On Air,
the podcast of the European Centre for Disease Prevention and Control.
Keeping up to date with European epidemiology.
Welcome to ECDC On Air, the podcast of the European Centre for Disease Prevention and Control. My name is Caroline, and I have Helena de Carvalho Gomes with me here for this episode of ECDC On Air. Helena is the Deputy Head of Unit Scientific Evidence and Communication, and she worked as a clinician in gynaecology and obstetrics before joining ECDC, at a time when the HPV vaccine was not yet available. When we mention cervical cancer, we have to talk about human papillomavirus, in short, HPV. HPV is the main cause for cervical cancers in women. Among the several hundred different types of human papillomaviruses, at least 14 are classified as high risk. And with high risk, we mean that these types are known to cause cancer, including cervical cancer. There are different vaccines on the market against HPV, and the HPV types covered by the 9-valent HPV vaccine, for example, alone are responsible for up to 90% of cervical cancers. HPV vaccines have been licensed for use in Europe since 2006, and by now, all EU/EA countries have implemented funded programs to vaccinate girls and boys. Thank you for joining us today, Helena. Could you give us a brief update on what you did when you worked as a clinician in the field of obstetrics and gynaecology, and what did you do, and how did it relate to HPV and cervical cancer?
I worked as a clinician already quite some time ago, 25 years ago and longer, in obstetrics and gynecology. So I was a young doctor at that time, and I was doing the regular rotations in a large university hospital in Germany. So it was the usual department. So we were working with gynecological patients, we were delivering babies, we were working with reproductive medicine, ultrasound, etc. I was also part of a working group that was taking care of an outpatient clinic that was working or taking care particularly of patients with cervical dysplasias. So that is now, of course, a technical term. So this is when you do the regular cervical cancer screening and your doctor detects that something could be indicating that your cells of the cervix are changing. And so these women would very often be referred to us as a specialized clinic for these cases. And this is how I started working particularly with cervical cancer patients. But the majority actually of the women that I would see were patients that had pre-cancerous lesions. So the changes of the cells before it develops into cancer.
Can you please tell us a bit more about HPV, so human papillomavirus, and what it is or what it causes?
So at that time, it was already known that the majority of cervical cancers were actually caused by human papillomavirus, or at least that the human papillomavirus played a very, very important role, causal role in the development of cervical cancer. But we had no vaccine or anything at that time. So the preventative measures that we had were cervical cancer screening, what is very often also called the Papanicolaou test. And human papillomavirus does not make any symptoms. It's a very, very common infection. And in most of the cases, it does also not create any problems. There are human papillomaviruses that are so-called low-risk viruses that can cause warts. This is also something that is very, very common in all age groups, and they are usually affecting the skin, very often the skin on the hands and feet. And this is actually something that probably everyone has known. It's very, very common also, especially also in children and young people. Then there are high-risk human papillomaviruses. And these were, of course, the ones that we were interested in also at that time. And these are the ones that actually can cause cancer. And the cancer where actually the correlation or the causation is really well known and was already well known at that time is cervical cancer. But at that time, that information did not help as much further because, yes, we could test already women if they would be HPV positive or not. We could also distinguish between high-risk and low-risk papillomaviruses. But that was it. I mean, we could not do anything with it at that time. We could, because once you are infected, there is no treatment for it, or there is nothing that we can actually give the woman, and the woman gets, or the person gets rid of it. Also to make clear that not only women can be affected. I'm talking now mostly about women because I was working in obstetrics and gynaecology, and of course the large majority of the people that I would see were women.
You mentioned that HIV infections can, for example, or most often do resolve on its own, that we won't necessarily notice. But what happens when our immune system, for example, does not clear the infection? And what does HPV have to do with cervical cancer then? Is it an immediate effect afterwards? You touched on it, but just kind of clarifying again.
I think that the majority of us actually is being infected with human papillomavirus at a young age. It's probably the majority really of us, but without knowing it. As said, it does not make any symptoms. The low-risk human papillomaviruses can create these warts. That is, of course, very visible and can also be very disturbing to people because it is something that everyone can see, etc. So it can also lead to stigma and so on. But they usually do not develop anything more malign from there. Then we have the high-risk human papillomaviruses, and they have a preference. They have a preference for mucosa. And these are the layers of our skin that are actually basically on the inside of our body. So they have contact with the outside world, but they are the inner layers of all our openings, for example. Usually we clear these infections within weeks or months, and we mostly don't even know that we have ever been infected. For reasons that are not very well known. We know that, of course, the immune system plays a role. We know that because people with a weakened immune system for several different reasons have difficulties in clearing these human papillomavirus infections. But we don't know why some people that actually appear very healthy and where we don't have any symptoms that the immune system is weakened don't get rid of the virus. And if the virus persists, those cells that are constantly changing, this is what we call dysplasia in gynecology, those pre-cancerous changes that we can see if we do the cervical cancer screening, and we actually remove some cells and check the cells in the microscope, and we can see that those cells are slowly but steadily changing. And at some point, that can change into cancer. Cervical cancer is a cancer that develops very slowly and over several years and through precancerous stages. So therefore, it is a cancer that gives us a lot of opportunity to be detected at early stages. One of these detection mechanisms is the cervical cancer screening. At the time when I was working still as a clinician, that was the only measure that we had to detect this cancer early. And this is what we were doing. So it is something that develops slowly. And as said, the majority of people actually clear the infection by themselves without ever knowing that they have been infected. It's a very, very common infection.
This infection per se, is it treatable if I would notice that I'm infected?
The infection as such, like many viral infections, we don't really have treatments for it. Around 25 years ago, when I was still working as a clinician, so what we had in our toolkit regarding cervical cancer was cervical cancer screening. So this was the preventative measure that we had. We knew about the link with human papillomavirus that had been speculated already in the 70s, and it was basically confirmed 10 years later by Harald Zurhausen, a German virologist, and he got in 2008 the Nobel Prize for it. And of course, we were all hoping already at that time that this would give us more that we could do to actually prevent cervical cancer even at an earlier stage. Because treating even the pre-cancerous lesions is invasive, is through surgery, although we tried already at that time to apply as minimal as possible surgery there. But we were dealing with partly very, very young women that had still family plans, and manipulating the cervix can lead to difficulties later on with pregnancies and fertility. Already at that time, we were all hoping that this knowledge that we had gained, that the majority of cervical cancer was caused by high-risk human papillomaviruses, would at some point give us an instrument, a vaccine hopefully, that would prevent this, prevent already the infection, and with that preventing the development into cervical cancer. A lot has actually changed in these last 25 years. We have a vaccine by now, which is really great, because since almost 100% of cervical cancer cases are caused by high-risk human papillomavirus, we can, through vaccination, almost eliminate cervical cancer. But it's not just the cancer that we can eliminate. We can also prevent young women from developing pre-cancerous lesions that also have to be treated and can create also suffering. For me, it was really, really great news hearing that a vaccine is available. Even better news to hear that it's highly efficient and does really its job, while at the same time being really very, very safe. With safety, I mean, of course, that it does not create severe adverse events, because, of course, you can have redness, you can have pain in your arm. It's very similar to other vaccinations.
Can you maybe share with us also the impressions that you had or the difficulties that you were experiencing as a clinician at the time?
I mean, it is one of the things that changed in 25 years. There were many other things that changed also. The treatment for cervical cancer is much better now. The cytology, so the Papanicolaou test, is also much better than it was at that time. It is combined now with technology that supports basically the human being in really checking the cells, and with much, much higher precision than what we had at that time, where we were basically really manually processing the cells and checking the cells under the microscope, which is, of course, also prone to mistakes. So I think a lot of things have really improved when we think about cervical cancer. So it's not just a vaccine, but the vaccine is, of course, an instrument that helps us preventing already all of this. At that time, it was partly difficult because, as said, I was involved in a team that was taking care or running an outpatient clinic where we would see a lot of patients that would be referred to us by their gynecologist because they had dysplasia, because they had several suspicious Papanicolaou tests in a row. So they would send these patients to us, and very often those patients would sit in front of me thinking that they had cancer. so that this is already a cancer diagnosis, the pap test, and that I would basically tell them how long they actually had to leave. The nice part of my job at that time was that I could, in most of the cases, relieve these patients from that, because I could explain that what we are seeing is not cancer, but are the pre-stages of cancer, and that we already can do something about it now, although it is small surgery, so it is invasive, but we can do something to prevent it from developing into real cervical cancer. That was the more positive aspects, but I, of course, also had patients, and I think this is something that probably would stay with me forever. For example, the case of a young mother with a 6-month-old infant and a toddler that was not even 3 years old with advanced cervical cancer. She was in her early 30s, so really a young mother, just a few years older than myself. And she was begging me to give her another 5 years of her life. And we knew that we can't do that, despite very, very radical treatment that we had to do with her at the time. So she did not live for another 2 years, and she could not see her children grow up. And already at that time, I thought this should not happen, because it is preventable. And I was not even thinking about a vaccine at that time, because it didn't exist. I was thinking about the cervical cancer screening, because she had been going to those screenings regularly, and it was not spotted. A cancer that usually develops over really several years, and it had failed her. So that was really something where I thought we have to be better at this, and where at the same time I really, because we knew that there was work ongoing on vaccines. It was very exploratory, and we were not there yet. I think it was around, when I worked in clinics, it was at the end of the 90s and beginnings of the 2000s, and the vaccine was introduced, I think, around 2006, and in some other countries later than that. So at that time, we were hoping for a vaccine, but it was not existent yet. So it's actually one of the reasons why I explored if there are other ways of improving these programs, and I looked into public health, because I thought I can then basically maybe do more in public health than just treating individual patients. So it was basically one of the triggers to change a bit my career path. I have quite a connection actually to HPV and cervical cancer from that perspective, because it somehow guided also the career that I chose, although I am not specifically working on HPV and cervical cancer right now.
Thank you so much for sharing those personal moments there. As a former clinician and a mother and working in public health, do you have a special message you would like to share?
I think it is quite important that we should use the means that we have that are, like sometimes I think, why are we discussing it so much? It is such a blessing that with a little intervention, such as giving a vaccine, we can prevent such a horrible disease. So sometimes I ask myself, why are we not doing it? I mean, having seen how the treatment then actually looks like for cervical cancer, which is really very, very radical surgery, and especially if we only spot the cancer at an advanced stage. I, as a mother, I have vaccinated my children, for example, as soon as HPV became available and they were in the age to be vaccinated. And to be very honest, I have 2 boys. I mean, they will never get cervical cancer. But I explained to them at the time that this is something that can infect both boys and girls. And even if they have not a cervix themselves, they have other body parts that can be affected. But they are basically also protecting their future partners. And they did not question it anymore. They actually thought, yes, of course, we will do it. I mean, we also got vaccines against other diseases. And we don't want to get sick. So if there is a vaccine that can protect us, we will do it. I think it is quite important also to say that despite the vaccine, and we are seeing really now tremendous results because, as said, cervical cancer develops quite slowly. So we are seeing now studies showing that actually girls that were vaccinated when the vaccine was first introduced, 2006, 2007, 2008, that enter now the age where cervical cancer screening starts, that the number of pre-cancerous lesions and also of cell changes has really dramatically gone down. And I think this is such a success story. So, but we should not stop the cervical cancer screening because the vaccines are preventing the majority of it, but they do not cover all high risk, although the large majority, almost 100% of the high risk types of human papillomavirus. But until, let's say, everyone would be vaccinated, it's quite important that we continue also to go to the cervical cancer screening, also as a woman. I am doing that. These are two tools that we have that are really preventing. The screening as such will not prevent the cancer as the vaccine does, but it is a means to detect those cell changes at an early stage. It's the combination of these two things that I think that it's quite realistic probably to say that we can maybe, if not eliminate, then reduce cervical cancer substantially.
That's a good note to end on, that we have hope to eliminate or drastically reduce the numbers of cervical cancer, not just in Europe, but hopefully worldwide.
Yeah.
So thank you very much for taking the time, Helena. And thanks for listening to those outside.
Thanks for inviting me.
Thank you very much for tuning in and for listening to this episode of ECDC On Air, marking Cervical Cancer Awareness Month. If you're interested in more information about HPV, check it out on our European Vaccination Information Portal, available in 24 European languages. Check out websites of your national health institutes or talk to your GP. Stay safe. Thank you for listening.